Hello, everyone. My name is Brenda Banwell. I am the Chief of Neurology at the Children's Hospital of Philadelphia and a Professor of Neurology and Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. It's my pleasure today to speak with you about current perspectives in pediatric multiple sclerosis care and research. Today's presentation is accredited, and as you can see on the slide, physicians can obtain Category 1 AMA credit for attending this lecture. Nurses can obtain 1 contact hour of nursing education as well. Pharmacists similarly qualify for 1 hour of continuing pharmacy education, and physician assistants and advanced practice providers can also claim 1 hour of CME credit. So thank you for joining me, and I will also emphasize that psychologists, social workers, and other allied health professionals, as illustrated here, can also obtain credit for attending today. My disclosures are that I serve as a consultant to Roche and Novartis on the safety and conduct of clinical trials, and have provided non-remunerated advice on similar topics in the past to the groups listed here. I am fortunate to receive grant funding from the National Institutes of Health, the National MS Society, and the Canadian MS Society. So today I'm going to review the application of the diagnostic criteria for pediatric multiple sclerosis. I'm then going to share with you some recent data comparing the clinical and imaging features of multiple sclerosis and myelin oligodendrocyte glycoprotein related demyelination in children. And finally, we're going to talk about the current therapeutic landscape for children living with multiple sclerosis. So it's always important to start at the beginning. The first event of multiple sclerosis or other demyelinating syndromes begins with an acute demyelinating syndrome or ADS. This first clinical presentation, almost always in a completely healthy child who develops over the course of hours to days, typically days, new neurological deficits, is the beginning of a journey. And that may begin with transverse myelitis, as shown on this slide, where there's a small focal spinal cord lesion. May begin as a monofocal demyelinating episode in the brainstem, as illustrated on the bottom. Maybe optic neuritis, as illustrated on the far right, with a clearly inflamed and expanded optic nerve. Or can present with rather dramatic imaging features. On the bottom, you see a child presenting with polyfocal demyelinating symptoms. So this child had sensory deficits and motor impairment, and an MRI that showed 149 T2 bright lesions at his first MS attack. In the center is a child with acute disseminated encephalomyelitis, or ADEM, and this child, a 7-year-old, presented with encephalopathy and progressive confusion, leading to requirement of intensive care, multiple neurological findings, including brisk reflexes, ataxia, and visual impairment, and ultimately had a single event, excellent recovery, as is very typical of ADEM in young children. When you see a child with any of these first manifestations of acute demyelination, one of the most important questions is this event the beginning of multiple sclerosis? Is this a one-time event, hopefully with excellent recovery? Or might this be the sentinel event of other demyelinating disorders that I'm going to speak about today, notably the first event of expression of myelin oligodendrocyte or MOG related demyelination? So one of the most important things about multiple sclerosis in children, just as in adults, is that the MRI provides a window into the pathology of this disease. MRI features of multiple sclerosis in children and in adults have guided us to prompt diagnoses and have helped us rule out other conditions. So this is a series of images from a 14-year-old with multiple sclerosis. And her imaging highlights several really important features. On the T2 flare image, you can see that there are some T2 bright lesions that are ovoid or rounded in appearance, very characteristic of multiple sclerosis. You can see that in the periventricular white matter, there is both a plethora of bright T2 lesions as well as a confluence of lesions, leaving a hazy or what is often referred to as dirty white matter looking appearance surrounding the ventricular white matter. This propensity for periventricular involvement is highly characteristic of MS across the age span. You can see that at the beginning of her disease, at the first event, she had quite a bit of enhancement with different enhancing patterns. So you can see that she has some small areas of enhancement, tiny lesions that are filled in, if you will, with gadolinium. She has a ring enhancing demyelinating lesion, and she has other lesions that are somewhere between those two appearances, emphasizing that the enhancement pattern in children, just like in adults, can be quite variable across different lesions. And then perhaps surprisingly, certainly it was to me at the beginning, she already has on a T1 weighted image shown on the bottom, an area of focal T1 hypointensity or a black hole. Now this black hole is already present at her first demyelinating attack. And when you look at that in combination with the FLAIR images that clearly show multifocal lesions and even likely coalescence of lesions that have been there for some time, these two things in combination emphasize that the first attack of multiple sclerosis is absolutely not the beginning of this disease. The preclinical or subclinical phase of multiple sclerosis clearly predated this first MRI scan. There had to have been time for this child to have acquired both a large volume of inflammatory disease and areas of focal permanent brain injury. And that is also true of adults. The challenge in both children and adults is we do not know how long that preclinical phase lasts or exists. In a young child, by definition, it cannot have been that many years, given that they are only 7, 8, 9, or 10 years of age at that first event. But we really don't know what that preclinical disease duration is. Now, one of the most important advances in our ability to diagnose multiple sclerosis has been international consensus diagnostic criteria. The McDonald criteria, named after Ian McDonald, who was one of the pioneers of MS diagnostics, have evolved over time. There have been different versions, each one trying to revise and improve and accelerate our ability to confirm a diagnosis of multiple sclerosis, and to do so both with accuracy and with specificity, as well as with the ability to do so as early in the disease course as possible. The 2017 revisions of these criteria, just like the 2010 version prior, specifically do include children in the diagnostic algorithm. Versions prior to that did not. So with that in mind, the 2017 criteria, when compared to the prior 2010 version, made some important but subtle changes. First of all, the presence of spinal fluid oligoclonal bands, so immune globulin proteins present in spinal fluid but not serum, can now be used to add to the confirmation of dissemination in time. In other words, these have been there for some time and are an indicative finding of chronic disease. In adults, oligoclonal bands are present in over 90% of individuals diagnosed with MS. The percentage in children is probably lower, although studies that have evaluated oligoclonal bands in pediatrics have varied both with experience of testing for oligoclonal bands, which is less commonly done in a pediatric setting. And then more recently, as we'll talk about later, now that we're able to eliminate children with myelin oligodendrocyte or MOG-related disease, oligoclonal bands in those with confirmed MS are much more prevalent. So probably at least 80% of children with MS do indeed have oligoclonal bands. The 2017 revisions also included cortical lesions as a lesion location that could help confirm dissemination in space. And this rests not only on improved imaging, which allows us to see these lesions, but also on pathology studies that have highlighted that although we think about multiple sclerosis as a white matter disease, it is truly a disease of the brain broadly, and cortical pathology is prominent. And finally, the 2010 version of the criteria restricted counting, if you will, of a lesion if it was thought that that lesion was causing symptoms, and it required that the criteria evaluate clinically silent lesions. This was found to be overly restrictive and not actually helpful, and so that limitation was removed, and all lesions count in the 2017 version. And so one of the most important things to do whenever there's a diagnostic criteria put forth is to evaluate how it performs in a cohort of patients, in my case, pediatric MS patients. And that is in fact what we did. So one of our fellows, Dr. Fada, and our team evaluated the applicability of the 2017 criteria in 324 pediatric patients, 71 of whom confirmed to have multiple sclerosis on the basis of relapsing disease, and 253 children who did not have multiple sclerosis, some of whom have MOG-related disease and others who had a monophasic disorder without serological antibodies. As is appropriate for a pediatric study, the median age of our patients was 10, with the youngest being less than a year of age, and by virtue of our cutoff, the eldest being younger than 18. This is a prospective cohort of patients that have been followed from study inception in 2004. So we had quite a duration of follow-up in our patients. We had 2,902 MRI scans to evaluate, and our patients had oligoclonal band evaluation and serum antibodies run in a consistent way in a single lab, looking for antibodies to MOG and aquaporin 4. Now, this is far too busy a slide, and I'm not asking you to read the individual parameters. I'm illustrating that we looked quite broadly at different imaging features that we and others had previously demonstrated as being helpful in identifying either children with MS or children who were unlikely to have MS. And when we did that, there were a few features that very clearly rose to the top as being helpful in distinguishing whether that first event, and I should mention these were all scans obtained within 30 days of a sentinel first event. And now we're trying to determine, is this a patient with MS or not? So the presence of even one black hole was extraordinarily helpful and emerged as our top feature that identified a patient with MS. The second feature was the presence of T2 bright lesions perpendicular to the long axis of the corpus callosum. In other words, Dawson's fingers. And both of these top two MRI features are what you might intuitively expect as being particularly helpful. One, the black holes, which implicate chronicity, and the perpendicular lesions being very characteristic of MS. We also showed that contrast enhancing lesions identified children with MS. Conversely, the absence of periventricular lesions argued against a diagnosis of MS. And then when we looked at our biological samples, the presence of oligoclonal bands did indeed support the diagnosis of MS in children, just like it does in adults. And the presence of anti-MOG antibodies strongly argued against a diagnosis of MS. So in aggregate, when we then looked at the McDonald criteria and its dissemination in time and space components, as well as comparing to the 2010 criteria, as well as other criteria that have previously been used listed here, we showed a few key findings. So in the blue, the darker blue, we show that the sensitivity, specificity, positive and negative predictive values of the 2017 criteria are strong. So the sensitivity is over 70%. The 2017 criteria are highly specific, have a very good predictive value for positive prediction, and then importantly, a very strong negative predictive value. In other words, if you don't meet the criteria, your chances of having multiple sclerosis are quite low. It just of interest, when you look at the Verhey criteria, which was the presence of a single black hole and a single periventricular T2 bright lesion, those criteria actually still perform the best. So in children at least, the top two of our variables actually are the most discriminatory in identifying children with MS compared to children who do not follow an MS disease course. So one of the most important things about making the diagnosis of multiple sclerosis has and will always be excluding other diagnoses. And now we have the ability as a community to increasingly gain access to high quality laboratory evaluation for the presence of antibodies against myelin oligodendrocyte glycoprotein. As illustrated in this diagram, MOG is a protein present on the outer lamella of myelin. As such, it is readily visible to the immune system. It is a small portion of CNS myelin, but it appears to be one that the immune system is very capable of recognizing. So in this illustration, this is again the same cohort of children that I mentioned in our 2017 evaluation program. Our study, which has been, as I said, running since 2004, obtained serum samples at baseline, 3, 6, 12 months, and annually in these children. And so when the ability to measure MOG antibodies was developing, and when cell-based assays like the one I'm illustrating here were developed, in this case by our collaborator Patty Waters in the United Kingdom, we went back to those archived samples and ran in an aggregated way this MOG assay to determine what portion of children had MOG antibodies. The nice part of the study was that these 430 children were not pre-selected in any way by our ability to think they might have MOG antibodies, because for the most part, they were all enrolled well before we knew MOG antibodies contributed to CNS demyelination. We did know from prior work that MOG antibodies are not expressed forever, and therefore we explicitly only evaluated the 274 children for whom we had samples obtained within 45 days of onset. This is extremely important, and I'll come back to mentioning this again at the end. But if you measure MOG antibodies 6, 12, 24, 36 months from when a child first presented, and they're negative at that point, you don't know whether they were negative at onset. So in this study, we had 274 children with these early samples, and we found 179 were negative, 84 were positive, and 11 had borderline results as illustrated here. We evaluated these children over time and found a variety of findings. First of all, MOG is not rare. MOG antibodies were present in a third of our cohort. They were disproportionately present in younger patients. And as illustrated here, 77% of the patients that had MOG antibodies at onset were 11 years of age or younger. So MOG antibodies are particularly prominent in our youngest patients. And this is illustrated here where when you're under age 11, almost half of our patients had MOG antibodies. In contrast, for those that presented at 11 years of age or older, only 15% had MOG antibodies. So what happens over time? So first of all, if you were negative at the beginning, like that very first sample in that first month to 6 weeks post-onset, you stayed negative. So we did not see the emergence of MOG antibodies in these samples. And I should mention that the median number of serial samples extended over 5 years. If you were positive at the beginning, about a third remained positive over 6.6 years in this particular group of children. 57% converted to being seronegative. And as you can see in this graph, they did so reasonably promptly, the majority in the first year. And 7% went up and down over time. And as you can see here, when we compare the children with ADEM to the children who did not have ADEM, those with ADEM became seronegative more quickly. So that study illustrated a few very important points. First of all, MOG antibodies contribute sizably to the acute demyelinating syndromes that we see in children. Antibody titers do not persist forever. And not shown in those slides, but as an important comment, the presence of MOG antibodies at baseline doesn't predict whether you're going to relapse. Even persistence of antibodies is not particularly reliable in identifying those children with MOG-related relapsing disease. We need better biomarkers to determine which of the children with MOG antibodies are going to have more relapses and which children are going to be monophasic. In our study, 70% of the children with MOG antibodies have not had any clinical or imaging new disease after more than 5 years. And that's quite similar to this study that I'm showing here, which was a collaboration of multiple groups led by the Spanish Pediatric Anti-MOG Study Group, where they looked at a pretty similar size cohort of children with suspected demyelination, but compared it, interestingly, to a large cohort of children with suspected encephalitis without demyelination. Just like we did, they were strict on making sure patients had early samples and quite a long period of follow-up. And what they found is that 94 out of 264 children had MOG antibodies, very similar to our percentage. 22, though, of the almost 500 children with encephalitis were also MOG positive, even though their MRI scans did not show demyelination, and their presentation was confusion, seizures, encephalopathy without any polyfocal neurological deficits. And here are some MRI features of children with MOG. So this is one of our patients, a 4-year-old with MOG positive demyelination, showing very characteristically a T2 bright lesion in the cerebellar peduncle, ill-defined lesions supratentorially that tend to appear juxtacortical, but not in that ovoid appearance that is more characteristic of juxtacortical lesions in MS. A second child on the bottom panel, with also a fairly similar presentation clinically, also highlights the predilection for lesions to hit the cerebellar peduncles and cerebellar white matter, deep gray structures as shown in both children, as well as ill-defined lesions in the higher white matter regions. Not shown on the MRI scans, but important for both these children, is that they both had longitudinally extensive myelitis, with the 4-year-old also having prominent involvement of the conus of the spinal cord, which is very common. If you have spinal cord involvement of the lower spine is common in children with MOG-related demyelination. Both of these children recovered incredibly well without ongoing relapses. Now, not all children with MOG do well. These are some illustrative examples of what can happen in MOG-related demyelination. So in the 7-year-old shown here, you can see just this enormous, large demyelinating lesion. And in the 2.5-year-old below, you can see a pattern that not only shows quite extensive bilateral disease, but also prominent bithalamic involvement in this patient. And taking that even a step further, as illustrated in this paper by the UK group, some children with MOG-related demyelination have an almost leukodystrophy appearance with widespread bilateral T2 bright lesions, an enhancing rim, as you see on the bottom image there, which is reminiscent of what we see in adrenal leukodystrophy, for example. And unfortunately, in some of these children with this leukodystrophy-like presentation, the outcome is poor, with these children developing often progressive neurological deficit and cognitive involvement. Now, this paper, this series of images comes from the Spanish group that I showed you a few slides ago, and just highlights again these interesting differences in MOG-related demyelination. So the 3-year-old on the top panel presented initially with an ADEM-like picture, as is the most common of the demyelinating presentations in that age group. And over time, even though her initial presentation showed smaller areas of T2 hyperintensity, as you can see evolving over to the right, over time that became very confluent with a truly leukodystrophy-like pattern and with progressive brain volume loss. The second child in their group here was a 9-year-old who presented with encephalitis and seizures, quite difficult to control seizures initially, did well initially, and in the second image the lesions seemed to resolve. Unfortunately, the child developed recurrence of both seizures and encephalopathy a year later, and as illustrated in this MRI scan, not only were there new T2 lesions, but over time, this child developed quite extensive and progressive brain volume loss. The 3-year-old in the third panel presented with the extreme of this encephalitic presentation with bilateral extensive cortical involvement, laminar necrosis, as illustrated across those panels, and again, a progressive permanent brain injury. And finally, the bottom image, also of a 3-year-old, presented with optic neuritis, fever, hemiparesis, and had, at least in cerebral imaging, this cortically based lesion with a patchy enhancement pattern as well as leptomeningeal enhancement that really made the authors think about CNS vasculitis. I know that they, our group and others, have children who have been diagnosed with central nervous system vasculitis, who we now know have MOG antibodies. So I illustrate this point to say that MOG antibodies can associate with a rather broad phenotype of important and often serious presentations in children. So while you're not here to take this quiz in person, I would normally have you put your hands up and ask you questions about what you're seeing on these images. But these are different images of patients with different patterns that I thought you might find interesting to try to say, in your mind, which of these children do you think have multiple sclerosis based on this MRI? Which children in this set of images do you think might have MOG-related demyelination? And in fact, the first patient is one of my teenage patients who has followed a rather typical course with relapsing remitting multiple sclerosis and who's now doing quite nicely on disease-modifying therapy. Second set of images is a more aggressive appearance. This is images from the Spanish group illustrating more cortically based lesions, as you can see on the coronal image, and who required, according to the authors, more aggressive treatment choices. The bottom is a child with aquaporin 4 related neuromyelitis optica, showing this diencephalic and interesting looking central MRI appearance. And finally, the bottom are images of children with MOG-related disease with this widespread white matter appearance and the prominent cerebellar peduncle appearance. So to comment, to conclude about MOG antibodies are present in about a third of children presenting with a first attack of demyelination, and in almost half if they're younger than 11. In incident cohort studies that are not pre-selected by phenotype, the presence of MOG antibodies at onset portends a monophasic course in up to 75%. Not all cohorts have this number. Some have shown relapsing disease in almost half of their patients. And of course, like all cohort studies, it may depend a little bit on how patients present to different centers and whether they're more likely or less likely to do so based on having relapsing disease. That being said, about half of children with MOG antibodies will become seronegative by 12 months. Anti-MOG antibodies are very commonly found in children with relapsing demyelination who don't look like MS. And in those children, they tend to still be positive for MOG antibodies at that time. If they have relapsing MOG disease and they start off with ADEM, they tend to have ADEM followed by recurrent episodes of optic neuritis. In contrast, teenagers are much more likely to have relapsing optic neuritis or a more classic neuromyelitis optica spectrum disorder phenotype with optic neuritis and myelitis. And when detected in somebody you think has MS, MOG antibodies identify patients with a very atypical clinical course. Often with MRI scans that over time look less and less like MS, with relapses that are often rather constrained, typically to the optic nerves, and perhaps with, although this remains to be studied, a poor response to MS-related therapies. And with concern, in fact, that some patients with MOG-related relapsing disease may even do worse on some of the therapies used for multiple sclerosis, such as interferons and glutamer acetate, prompting the question of what is the optimal therapy for MOG-related relapsing demyelination. So back to MS and the treatment of our patients. So once one has excluded diseases that may mimic MS and has applied appropriate international criteria to confirm an MS diagnosis, one is then placed in the situation of advocating for prompt and effective therapy for our patients. Acutely, during an acute relapse, the majority of patients respond to corticosteroids. In children, we use 30 milligrams per kilogram per day to a maximum of 1 gram. In children who do not respond well to corticosteroids, or the rare child who has a contraindication to steroids, such as a brittle diabetic or a patient with other medical conditions that make steroids inappropriate, then immune globulin can be used. Life-threatening or life-altering demyelination, which I refer to as a patient with a devastating spinal cord attack, or a child with a brainstem lesion that is impairing respiration or alertness, or an extreme severe optic neuritis episode with poor visual recovery early on. Then in children, just as was demonstrated years ago by Brian Weinshanger in the Mayo Group, plasma exchange can be of significant value. Typically, we use 5 to 8 exchanges over the course of 8 or 10 days, depending on how the child tolerates the procedure. Symptomatically, I'm going to come to chronic therapy in a moment, but symptomatically, it is important to recognize that just like adults, pediatric MS patients also have chronic fatigue. Determining what is MS-related fatigue from what is teenager-related fatigue can be somewhat challenging, and certainly parents struggle in trying to help us separate that out. But teenagers will tell me very clearly. MS-related fatigue is being too tired to do something you want to do, to not having the energy to go play a sport or an instrument or attend an art class or go out with friends, or attend a social event that was very important to you. That type of fatigue is clearly not related to being a teenager. It is definitely a disease manifestation, and we do treat our pediatric patients with the same fatigue management strategies as we use in adults. Conserve your energy effectively, get adequate sleep, stay well hydrated, eat nutritious food, and then if needed, medications such as modafinil or amantadine can be prescribed with good effect. Our patients, unlike adults, are still in school, and symptomatic support in the education system, advocating for appropriate placement in classrooms and extra support if needed, and cognitive testing is absolutely pivotal. And finally, in terms of symptomatic on ongoing support, it is important to recognize that the 30 to 50% rate of depression and anxiety that is reported in adults is also present in our patients that begin their disease under 18. So adequate emotional support, mental health counseling, and psychiatric care are extremely important. So there's been a very nice review recently published by the UK group just recently, talking about the new era of diagnostics and therapeutics in pediatric MS. As shown in this nice table, there have been a variety of treatment options. There are now more than 15 for disease modification in adult MS. As summarized in this table, I won't repeat how these medicines are thought to work or their dosing, because that's readily familiar probably to most of you, but I think the pediatric considerations are the emphasis here. For many years now, since actually the first case report of interferon beta 1b in an 8-year-old in 1984, we have used interferon as a mainstay of first-line therapy for pediatric MS. As that has been reported, younger children, particularly those under 10, can have a transient elevation of their serum AST and ALT values, which typically normalize if the dose is reduced and a little bit over time. Otherwise, the general tolerability of interferon-related therapy in children is very similar to adults, which is flu-like symptoms in proximity to the injection, which tend to get better over time, although not always. And then the invariable challenge of injectable therapy. So of course, there's the sub-Q formulations, there's intramuscular formulations, and now there's intramuscular formulations with reduced frequency of injection. Even with all of those, there remains the challenge of giving an injection to a child. Glatiramer acetate or Copaxone, we have also used in the pediatric community for pediatric MS care for now over 20 years. Other than the rare hypersensitivity sort of experience where patients feel flushed and maybe a bit tachycardic, which tends to occur in the majority of patients, if it does, only once or maybe twice, and is greatly helped if you warn them that that might happen. Once that is passed, if it occurs, the main challenge in treating children with glatiramer acetate is the frequency of injection. So even with the formulation that is now 3 times weekly as opposed to daily, the injection related frequency remains a stumbling block for many children. The Italian group published years ago on the benefits of natalizumab in a cohort of pediatric onset MS patients, particularly selected on the basis of high relapse rate, and all of whom in that study, I believe, were JC virus negative at least onset of therapy. And they reported a very dramatic benefit in terms of pre to post-treatment reduction in relapses. Now, this is not a clinical trial, so you can't take those numbers as precise evidence, but there was clearly an overall benefit in relapse rate reduction. Fingolimod, I'm going to talk about it more in a moment because this is one option that now has phase 3 clinical trial data. Teriflunomide is in clinical trial for pediatric onset MS, but the teratogenicity reported and the importance of sexual health and counseling is an ongoing important consideration for the use of this therapy in anyone, but added a little to the complexity of having those conversations with pediatric patients is absolutely pivotal. Dimethyl fumarate is in a clinical trial for pediatric patients as well. Alemtuzumab or Lemtrada does have an open label study in pediatrics, but as I suspect you're aware, there are concerns with the emergence of secondary autoimmune conditions, which make it a safety issue for serious consideration in pediatrics. And similarly with cladribine, the extent of lymphopenia and the risk of infection make it a challenging consideration in children who are still acquiring their normal infections of the classic infections of childhood, and which point significant immune suppression is often a major consideration. So with all of these different therapies, the debate now is where to start and in what order. So as illustrated in this nice slide that Dr. Chitnis has shared with me from our International Pediatric MS Study Group meetings, our conventional strategy certainly used to be that we started with interferon or glatiramer acetate. We made sure children tolerated it, or we helped them tolerate it as best we could. We evaluated their treatment response, both clinically and by imaging. And if relapses continued, there would be consideration perhaps of moving from interferon to glatiramer acetate or back the other direction. And if that did not work, then there would be consideration of moving to a second-line therapy. Now we have a different landscape. As illustrated here on a timeline, you can see the formal approvals as opposed to the initial uses, but the formal approvals of several of the current frontline therapies for MS in adults across the top. And then diagrammed on the bottom, the time frame for when some of the either open label or phase 1 or 2 trials were launched for pediatric MS. And we've got this nice cluster on the latter years emphasizing the new landscape of what I hope will be evidence-based care for pediatric MS patients availed of true clinical trial evidence. As I mentioned in my prior remarks, here are some of the active trials that are either completed and involved now in a variety of publications with the Paradigms study, or at various stages as illustrated here of completion of enrollment and or active enrollment. So I'm going to just discuss briefly the Paradigm study, which is the largest formal study completed in a phase 3 design. So following a pre-randomization phase, pediatric MS patients were enrolled in a double dummy, double-blind treatment trial and are now in an extension phase. The study compared fingolimod to interferon beta 1A by intramuscular injection. and patients were randomized. And of course, they either received fingolimod as the active drug with placebo injection, or they received interferon as the active therapy with placebo tablets. This study went up to 2 years, and the extension phase, where all participants have been offered fingolimod, will extend out to 5 years. The groups were well matched, as you can see by the age and distribution of core demographic features. I'd like to call your attention to a couple things that are very characteristic of pediatric MS. One is the number of T2 lesions in both arms of the study. The average was 40 lesions in both groups, which just highlights how much disease activity pediatric MS patients typically have early in their disease. The volume of lesions, as you can see, was quite high. And although we don't have a comparison study here on the whole brain volume, in separate research, separate from this trial, it has been clearly shown that brain volume in pediatric MS patients is smaller than age expected, and that pediatric MS impacts age expected brain growth. So what did we learn in this trial? First of all, we learned we could do it. I think one of the biggest successes of this trial was that it was successfully enrolled and completed. And when you think about the challenges of having children participate in clinical trials, of missing school, of parents having to miss work to be part of clinical trial work, it is a really important statement that this randomized study was successful and completed. There was no question about the difference in groups. As you can see here, the patients that were in the active fingolimod arm had an 82% relative risk reduction for relapse compared to the children being treated with the active comparator, interferon beta 1A. Importantly, the time to first relapse in the study was significantly delayed in the children receiving fingolimod compared to those on interferon beta 1A. And really important, when you think about missing school for relapses, 87% of the children receiving fingolimod were free of relapses throughout the 2 years of the study, or up to 2 years of the study, compared to 38.8% of those receiving interferon. So this is a sizable reduction in morbidity. Relapses, of course, are terrifying for anyone living with MS, but they disrupt quality of life. They pull children out of school. They necessitate frequently a relapse-related therapy. So this difference, I think, is clinically meaningful to the patient and their family. The Paradigm study also showed that fingolimod met its MRI secondary endpoints. So those patients on fingolimod had a lower rate, 53% reduction in the rate of new or newly enlarging T2 lesions, 66% reduction in the rate of the number of new GAD-enhancing lesions. The proportion of patients free of any new lesions was quite a bit higher, 4.5 times higher in the fingolimod arm, and the proportion of patients free of enhancing lesions was also similarly superior in the fingolimod arm. Importantly, though, if you look at the absolute numbers, it's relevant to note that even on a therapy that reduced relapse rates, relatively speaking, by 82% in the fingolimod arm, only 16% of those children were free of any new T2 lesions during the entire course of the study. So 84% of patients acquired at least one new T2 lesion, even when their relapse rate was reduced. So this means that while this therapy clearly had a clinical impact and a very strong MRI impact, it did not completely bring patients to what we call NEDA, or no evidence of disease activity. And that raises a good question. So now that we are at least availed of fingolimod as a therapy that, at least in the United States, Canada, and many parts of Europe, has been approved both for pediatric onset MS, but as first-line therapy in several of these countries, it raises the question, would you start with fingolimod as the first-line therapy, or interferon, or glatiramer acetate, or even not talked about on that last slide, therapies such as anti-CD20 therapies, or based on the Italian series, natalizumab, which, as I mentioned, they prioritized in pediatric patients with early high relapse rates. And so using that that sort of question, which of these children, looking at their first MRI scans, would you intuitively in your mind think might have the highest disease activity, and would that guide you perhaps to provide a arguably more potent therapy to one of these children versus another? Which I think is important is that although MRI scans do indeed have a lot of importance in our diagnostic algorithms, they certainly guide our differential, there still remains a disconnect between what the MRI shows and what happens clinically. So in that first graph there, that is an image of a 17-year-old with multiple sclerosis who over the course of 2 years had 6 relapses and had way more than 15 lesions, compared to a 16-year-old on the right who had 4 relapses in the same time period and only 4 lesions. On the bottom, a patient who looked like they had quite active disease, more than 15 lesions at baseline, only 1 relapse over the course of the next several years, and a 12-year-old who had only 3 lesions at their first MRI scan and only 1 relapse, so relatively low level of disease activity. How would we know whether this highly active MRI scan on the top, if we had predicted that that patient would have frequent relapses, we would have been correct, but an equally active MRI scan on a child of the same age on the bottom did not. And then similarly, low level of disease activity on first MRI scan did not reliably associate with low relapse frequency, as illustrated by the 16-year-old who had 4 relapses in 2 years. So MRI is terrific for many things, but in isolation does not appear to be as reliable as we would like at identifying which children might be best availed of more aggressive therapy, or as some argue at this point, maybe we should be using therapies that are known to be highly effective at onset for all of our pediatric MS patients, given that the natural history of pediatric MS is to be associated with a high relapse rate and frequency. So I want to move toward my conclusions, and I want to highlight a few things that we've not talked about in detail. The first is that MS occurs in the developing central nervous system during the key years of academic acquisition. MS in pediatric patients, as illustrated by the references below here, has been associated with global effects on intellectual functioning, but more specifically with difficulty with attention and executive function, with impairment in processing speed, with challenges in visual motor and visual motor integration, with some challenges in memory, particularly visual memory, and in some patients with challenges in rapid verbal fluency. Now, in aggregate, what does that mean for the child? Well, it really means high school is challenging. In high school, when we're expected to process information quickly, our patients can struggle. In high school, when we're meant to naturally think through and organize multiple tasks concurrently, the attention and executive dysfunction can be very disabling. Adolescence and high school education is associated with a period of time where teachers stop handing you all the information. They tell it to you and they expect you to memorize it. That can be very difficult if you have impairment in verbal or visual memory. And finally, many of our patients, when they were little kids, were terrific at a variety of activities, music, sport, and now they're struggling with visual motor integration, which is a pretty pivotal skill set for many of those activities, particularly some of the eye-hand coordination related tasks involved in either playing an instrument or playing a sport. So the impact of pediatric MS on the neuropsychology and health of our patients is pivotal. And I think one of the most important things we advocate for in all of our pediatric patients is to have a neuropsychologist as part of the care team and a strong liaison with our schools. And of course, I firmly believe that not only should we talk about medications and analysis, we need to talk about wellness. And wellness is a treatment. It's not the absence of disease. Exercise is important for all of us during this COVID period. I think the challenges for maintaining fitness and health have been emphasized even more than before. Pediatric MS patients, as illustrated by Dr. Ye and her team, exercise less vigorously than age-matched peers. This sets the stage for a reduction in body fitness, and as has been shown very clearly in adult onset MS, fitness is a very important protective mechanism against some aspects of MS-related disability. So being fit when you're young is going to set the stage for fitness as a core part of your therapy plan. Healthy weight is extremely important. I did not in this talk have time to go through the risk factors for MS, but both in children, teenagers, and young adults, one of the risk determinants for MS relates to a higher body mass index. So increased body mass index is not only a risk factor, but it also predisposes to other comorbidities that have now also been shown to make MS worse. Type 2 diabetes, immobility, hip fracture, just general inactivity. All of these contribute to the morbidity of living with another serious health issue like multiple sclerosis. So we really encourage our patients to have healthy weight. Low vitamin D levels have been implicated as a risk factor for CNS demyelination, and healthy vitamin D nutrition, while not directly linked to reduction in relapses, at least not at this early stage, there is some suggestion that having a healthy vitamin D level may have a benefit on your disease activity and certainly has a benefit on your bone health. And finally, just to re-emphasize what I've said now in several points in this talk, multiple sclerosis has a serious impact on emotional health. And it is imperative that we think about the emotional and psychiatric health of our patients. Depression, anxiety, and addiction are major concerns in teenagers in general. They are increasingly prevalent in today's society. And I think that they are comorbid and disorders that are of significant importance in both children, youth, and adults with multiple sclerosis. So to close, I think it's important to note that pediatric onset multiple sclerosis can be reliably used during the using the 2017 McDonald criteria, provided that other diagnoses have been excluded. One of the most important diagnoses to exclude is MOG-related demyelination, as the presence of these antibodies appears to rather reliably identify patients that are going to have a non-MS disease course. Many are going to have a monophasic illness. And for those that have relapses, the characteristics, and the response to therapy are increasingly recognized to be distinct from what we see in multiple sclerosis. And there's now an international MOG consortium working to try to better define MOG-related disease in pediatric and adult patients. Treatment of pediatric patients with MS is now informed by one large completed trial and soon to be others. And I think this is going to allow us to provide evidence-based care for our patients. We hope that these new therapies will impact not only relapses clinically, not only T2 bright lesions and black holes on MRI, but hopefully the degenerative aspects of MS. And while we did not talk a lot today about brain volume and about the changes that happen over time to brain volume in pediatric patients, I think it's important to note that there is evidence of progressive loss of brain volume from onset in both pediatric and adult disease. Mitigating that, as well as the degenerative component that may be happening at the cellular level, is clearly an unmet need across MS age span and across all forms of MS, relapsing, remitting, which is what we see in children, as well as progressive clinical expression of the disease in adults. Finally, the long-term effects of what we do are pivotally important to be monitored. It is very reassuring to see that you provide a therapy that reduces relapses and keeps children in school, makes them feel like their disease is something that they don't have to think about every day. All of those are wonderful advances, but it is an enormous responsibility to be sure that we follow our patients through adulthood in order to understand the long-term, hopefully benefit, but also potential consequences of early alteration of their immune system. And last but definitely not least, Not only do we want to understand the impact of MS during childhood, but it is extremely important that we understand what it means for someone who has had their disease begin when they were a child. How does that impact their quality of life, their social outcomes, their vocational and aspirational goals, and of course to also address the inequity that comes to anyone living with a chronic health condition as they try to complete school, as they try to complete post-educational training, and as they enter the workforce. So I'd like to conclude by welcoming all of you. If you are not already a member of the International Pediatric MS Study Group, I have the privilege of serving now as chair of this organization, and on behalf of my committee and the IPMSSG as a whole, we welcome and would be delighted to have more members. We already have more than 150 people representing 40 different countries. So please, if you're not a member, the website is here. We would love to have you. And this is another link to our webpage. And we have information there for families, for professionals, and for our industry partners to comment on advocacy for safe and effective clinical trial design. And I will end with a slide to thank the many people with whom I have the privilege of working on a day-to-day basis, and whose contributions to many of the either slides or comments that I've made during this presentation. We are a dedicated team that have been working and studying pediatric onset multiple sclerosis since 1999. And I thank all of them, as well as my funding sources for their ongoing support. And finally, I thank all of you for your attention, for being flexible in how you learn during this new and unprecedented time. And I sincerely hope that you're listening to this presentation with yourself and your family, colleagues and friends, staying healthy and safe during this COVID time. Thank you all.